And thank you all for staying to the final talk. I appreciate your durability. So I'm going to talk a bit about what's going on in the future. Here's what's going on. And as you could have told from the lead-in today, there's a lot going on. This has been a spectacular 2 decades in seeing research translated into therapies, especially for a neurological disease. And it's not stopping. And so just to remind you why neurologists study the brain, and this is the main reason, as quoted by Woody Allen. And you saw a little of this earlier, but I put it up because it's a slide of humility and also a slide of surprise. Humility is that this far along in MS research, we still don't know the cause. And as you heard from Dr. Kutzi, there's been an enormous investment in research, and we've learned an amazing amount of information over the years because of that research. But this is a tough disease, and in many respects, as you well know, and figuring out exactly what's causing it has been one of them. So there's many things here. There's much that we know, but the humility is what we don't know. The reason why this list is actually growing rather than getting narrower is that every time Dr. Kutsky gives someone a grant, they answer the question, hopefully, because he's careful about selecting who gets his money, but every question that's answered, if asked correctly, leads to 10 new questions. And that's the whole process of research, so we can get deeper and deeper into the process. So we still have lots more to do. The simplified version of what we've learned is just this. We know that there's a genetic predisposition to multiple sclerosis. You've heard about that. It plays a role, but it's not the defining element of the disease. There's an environmental trigger. We've known this for years. We have not figured out yet what it is. They interact together in a state of disimmunity more than autoimmunity, because we haven't proven that, to lead to the damage that actually occurs. And that's what we're trying to undo with the therapies and the things that we are going to be doing in the future. Right now, we have disease-modifying therapies, and you heard about those earlier from Dr. Miller and others. We treat acute exacerbations. You heard a bit about that. We have strategies for enhancing recovery from exacerbations. We have strategies that enhance function, no matter where you're at. We have symptomatic therapies that we haven't spent a lot of time talking about today, but these are important for you to discuss with your physicians, because whether your disease is very, very mild or very, very severe, there are things that be done to make your quality of life better, and we can handle that. Our next 2 horizons are neuroprotection and repair. Neuroprotection, we think, is going to be the key to getting a handle on progressive disease, because neuroprotection means strategies that will preserve underlying tissue, in this case brain tissue, from being damaged even after we turn off the immune response. And repair is part of Dr. Kutzi's restore. That is, even if we stop the disease now, we'd still have thousands of individuals, millions of individuals with damage to their nervous system that we want to repair. And this goes beyond multiple sclerosis, but to all neurological diseases. So this is our millennial issue, is to be able to repair the nervous system, which is the hardest of the organs to actually do that. And you've seen these courses many, many times. I only put them up now to let you know as we move forward in therapies, we have, for a variety of reasons, been locked into these characterizations because it made for homogeneous groups of individuals to study. But it also shows that some of these things were easier than others. So treating relapsing remitting MS has turned out to be much, much easier than treating any of the progressive forms of MS. And it's been a little hard to translate therapies from one type to another. But moving forward, we're going to see how we can do better, much better, with progressive forms of MS. And so what we have at the moment, we have treatments that you've already seen available for relapsing remitting MS, and Dr. Miller nicely reviewed those. For secondary progressive MS, we have therapies that are approved, sort of, but they're not that good, and especially with mitoxantrone, there are issues with toxicities and side effects. For primary progressive MS, we do not have approved therapies. We have some hints on how it's going. We have therapies studies underway And so I'll remind you that there are a couple of studies underway now on primary progressive MS to try and find new approaches to this, because none have succeeded thus far. And then the progressive relapsing form, we treat like secondary progressive, which means not terribly effectively. And then, as you know, we have this new type, CIS, clinically isolated syndrome, the first attack of MS. We treat that the same as relapsing remitting, and we have good data to support our therapies for that, which work well. And you heard a little bit about radiologic isolated syndrome, RIS, and we don't know what to do with those yet. And you already heard a discussion about that, so I won't reiterate it. You've seen this slide. We all steal slides from each other, as you could tell, and the really good ones get used multiple times over. So this one comes from Jerry Walensky. I use it here in a different context, and that is to let's see if this laser actually works, yeah, to highlight where we are. So we're actually rather good at treating early MS, relapse remitting form. But one of the things moving forward with the therapies I'm going to talk to you about is that some of them have the promise of excellent efficacy, especially in relapse-based MS. But they have some challenge side effect profiles and the potential for some significant safety issues. What we need to find out is whose MS is going to end up here. Bad, significant disability, a lot of damage to brain tissue and spinal cord and such, as opposed to those whose MS goes along for years, maybe their entire life, without doing much of anything to them. Because remember that of the serious neurologic diseases, multiple sclerosis is the most variable, far and away the most variable, from very, very mild to very, very severe and everything in between. The challenge for us in assessing risk-benefit, and Dr. Miller talked about this earlier, is also knowing what someone's going to do. Because if I could say to someone early on in the course of the disease, you're okay, you're not going to have an exacerbation for the next 10 years, I don't have to treat them with anything. And if I have another metric that says you're at risk for serious disability moving forward over the next 5 years, then I could choose a much more aggressive therapy for them because the benefit would outweigh the risk. We're not there yet. And Dr. Kutzik discussed some of the ways we're going to get at this by analyzing genetics and analyzing biomarkers and things of that sort, and I'll come back to that. But that's one of our big challenges moving forward, is working out how we're going to treat the disease early on, how to predict who we're going to give a therapy to, and get through these various courses. One of the ways we're going to do that is through biomarkers. And biomarker means beyond what we see clinically, and you can think of MRI as sort of a biomarker, but we kind of separate that out because there's so much work going on in imaging. But think of other blood tests that would give you an idea of what kind of damage is going on and potentially what sort of course with MS you'd have. There have been a number of candidates that have come along. We don't have any yet that we're particularly happy with, but there are a few that are looking interesting. Myelin antibodies at first looked interesting, and then in repeat did not. There are some immune markers which may tell us how someone's disease is going to behave, and maybe even more importantly, how they're going to respond to a given therapy. So there's some early work, for example, to suggest that the level of certain types of immune molecules in your body may be a predictor of whether you'll respond to interferon or not. This work has a lot farther to go, but it's a very interesting idea. We talked a little bit about genetics and genomics and being able to predict what's going to happen. Most of the large-scale genetic work that's been done thus far has looked at susceptibility. That is, are you at risk for MS and are you not? And those studies, which have some very interesting results, show that the genetics only counts for a small part of the risk. But the next step is going to be look at severity and what our genes tell us about this, how the severity of the disease will progress, and I'll show you more about that. Another biomarker is neutralizing antibodies. Some of you have been tested to see if you have antibodies to interferon beta. And if you do, we don't think the drug works as well or at all, and so that's a biomarker of sorts. And then there's another, this JC virus exposure, and Dr. Miller discussed that as well as a marker of whether you're at risk for what we consider the most significant side effect of use with natalizumab. Now, this is a simplified version of the immune response in MS. You should recognize this from earlier, but it turns out that mine's a little more complicated than the really simplified one we showed you earlier. This is the one for the test. And I put this up not to give you a late Sunday afternoon lecture on immunology rather than watching the second half of the Giants game, but rather to show you some of the things that we're learning about. And one is that the nature of your immune response may differ amongst different individuals and may determine how their disease behaves. So the type of immune cell, which are the two types circled here, that mediates the damage may direct the nature of our attack against that cell and what agent we would choose. Similarly, other cells may be involved, like B cells, and we're developing strategies to attack those specifically. In terms of a given individual's disease, in some people, we know there's a lot of loss of neurons, and that's important because they're hard to regrow, and while there's some natural ability to regrow neurons, they're the toughest cell in the body to restore. Others may just lose myelin. If that's the type of MS you have where you're just losing myelin, you have probably the best chance of avoiding difficulty and of benefiting from the strategies that we currently employ. And other individuals will lose their axons, the axonal nerve fibers themselves, and they also are more difficult to treat because those are tougher to grow. These are the sort of things, by using imaging metrics, like Dr. Inglesi was discussing, and some of the biologic metrics that we're working on now will make us better able to individualize therapy. This will be the true start of the era of personalized medicine. And here's some very preliminary work from a study that we were doing, still are doing, looking at genes. And if this graph looks familiar to you all, it's called a Manhattan plot for obvious reasons. But it's a measure of genetic frequency in individuals with MS. And in this case, we were looking for genetic frequency of individuals, comparing those with lots of disease on their MRI versus those with very little disease on their MRI. And what we found is that about 17 different genes may be involved in determining whether disease is mild or disease is severe. Early phase work, it's just being reconfirmed, but it holds the promise of giving us the potential for looking at genetic susceptibility and genetic severity measures. You saw this earlier again from Dr. Miller, showing you the annualized relapse rate changes. And I show you this as well because MS is very topical. It makes the news. I have little doubt that after our European meetings next week, you'll see lots of news items flashing up about work, because it's going to be a very interesting meeting, a lot of interesting work going on, and a lot of public relations firms, many of them here in New York, will be very busy over the next week spinning out the various results. We'll keep you up to date and come back next year for our talk, and we'll give you the true scoop on what actually went on, if you want to wait that long. But I point this out just to show you that things change over time, and this fact that these relapse rates here are all lower over the last 10 years, including placebo relapses, is not because we necessarily have better medicines and better placebos, although that may be the case, certainly the better medicines, but rather because things change. How we measure them change, the individuals who get into trials change, so it makes it very hard to make comparisons across trials. And so the take-home message here is, if you want to know whether drug A is better than drug B, you can't look at separate trials. They have to be in the same trial. The good news is that moving forward, many of these drugs I'm going to be talking about are in studies now where they're doing comparative trials, so we get some comparative efficacy information, which is sorely needed. Okay, so here's where we are now. This was the first wave of therapies with interferons, glutarin acetate, mitoxantrone, and natalizumab. And then the next agent, and our latest agent, which is this month, a year old, was fingolimod, which on here is called FTY-720 because that was its initial characterization, and it's easier to spell and takes up fewer letters than fingolimod. So that came out a year ago. We're using that. Dr. Miller filled you in on that. What's coming along or not coming along, we had another drug called cladribine, which we talked about last year, which had successful phase 3 studies, but will not come to market because there were safety concerns both here with the FDA found them and the European authorities, and for a variety of reasons the company chose not to pursue answering the safety questions, so you will not see cladribine, which was a pill. We have another pill called teriflunomide. Teriflunomide is in a development program now. They have just published this last week an article in the New England Journal of Medicine, of which Dr. Miller is one of the co-authors, on the results of their first phase 3 trial, which was a successful trial, and I'll show you some of that data. But if they get through the regulatory process, they could be our second pill on the market. Good efficacy, acceptable safety profile for that. Another pill, laquinimod, also has completed 2 phase 3 studies, one presented, neither of them published. We're going to have the second one presented this coming week. Interesting molecule. The effects on exacerbations were not terribly impressive, but it did have very interesting and significant effects on preventing disability or lessening disability, and also on lessening the amount of damage that actually occurred to the brain, measures of brain volume or brain atrophy. And so we'll be hearing more about laquinimod. Another agent, alemtuzumab. This is an intravenous infusion, like natalizumab is. Alemtuzumab is a very potent agent, which essentially lyses, kills off all of your lymphocytes, B cells, T cells, monocytes. It's a highly potent agent, knocks them off. You get 2 courses, and the cells are gone for at least a year, if not longer, for the most part. Very, very impressive phase 2 results. They've announced successful phase 3 results, and rather than go up against the placebo, they actually went up against one of the interferons and succeeded in reducing the relapse rate. They have not reported a reduction in disability, but the population they looked at had so little disability developed that it was nearly impossible to measure a difference between them. We're going to hear about their results late next week as well. And they have more studies in the pipeline. Another agent known as dimethyl fumarate, or BG12, we'll also hear about next week. They've reported by press release, not by presentation or publication yet, very impressive data of a pill that's given either 2 or 3 times a day. The 2 times a day data looked good enough that hopefully that will be what comes to mind, because taking a pill 3 times a day is difficult. But the 2 times a day pill looked to be, by press release, very effective, a highly acceptable safety profile, and we should be hearing more from that. So just looking at this group here, there are 1, 2, 3 more potential pills coming along. There's another agent, teclistamab, which is an infusion, another monoclonal antibody that's in phase 3 testing now, but has not finished yet, had a successful phase 2 trial reported not that long ago. And one that I didn't get onto a slide here was another agent which is entering phase 3 called ocrelizumab, which attacks B cells. Remember, B cells was one of those ones that I kind of circled back there, and it's another part of the immune system that, with a sister molecule called rituximab, had very good phase 2 results. Ocrelizumab had good phase 2 results. Now it's moving into phase 3. We've also been thinking about combination therapies. We're going to be reporting combination therapy results from our study of combining interferon and glatiramer acetate next spring. The study ends in January. Another very enticing combination strategy would be taking an immunomodulating agent, like all the agents that I've talked about thus far, and adding on a neuroprotective molecule. Attractive as that strategy may be, it's been very hard to find safe and effective neuroprotective molecules. This is a big challenge and a potential blockbuster idea, because if we can find a neuroprotective molecule in multiple sclerosis, it potentially could also be translated into other neurodegenerative diseases such as Alzheimer's and Huntington's chorea and Parkinson's and ALS and diseases of that sort. So that's a major area of investigation for us. And then the potential for an enhancer of repair, and there's some early phase studies now to try and inhibit the factors that exist within the body in individuals with MS that inhibit natural repair. You have the ability to repair your nervous system. In MS, this ability burns out, or something keeps it from doing what's normally supposed to do. And so there are a number of strategies being investigated primarily right now in mice, but human studies are getting underway to try and improve this repair, and I'll discuss that in a moment. This is just a reminder of our combination therapy, which, like I said, you'll hear more about in the coming months, and certainly I'll discuss it in greater detail at this conference next year. So we talked a bit about repair, and one of the exciting horizons in repair is cellular replacement therapies and enhancement. And I put those two together because it's not clear that when we put in cellular replacements, whether those cells are actually doing the replacing or enhancing the body's ability to do its own repair. And it's not clear, and there's evidence for both. And those of you who were here last year remember Dr. Jeff Cohen from Cleveland Clinic discussed these strategies extensively. And I'll just say we've just dosed our first patient with stem cell therapy. In this case, it's a protocol from a company called Celgene that uses stem cells taken from the baby side of the placenta. And these stem cells are then grown up and harvested and made such that we can give them to people. And so we've started an experiment along with a couple of other sites across the country, early phase experiment, to primarily see whether it's safe to do this and to start to get an idea of how to measure repair. And so this work is going on. Dr. Cohen's work is going on, as he had discussed here last year. And there's a few other places around the world that are getting into interesting and exciting stem cell therapies. There's also a lot of bizarre stem cell therapy things that are going on out there on the internet. You could buy them if you want, get them shipped on dry ice and drink them in the morning with your orange juice, but be careful. Some of the things that Dr. Kutsi alluded to that are moving forward and going from basic research to clinical research and realities are more testing of immune function, genetics, more work on environmental factors. You've heard a little bit about vitamin D and EBV, Epstein-Barr virus. These need to be proven that they have some value. You heard about imaging advances, and we talked a bit about regeneration and repair just now. So in the future, where are we going to go with therapies? Well, we're getting sufficiently good in reducing relapses that's going to be very hard to do any better than the agents we have now. Not because there's not more room for improvement, but because our ability to measure improvement becomes harder and harder the lower the level of attacks that occur. And we're getting down to very low levels. And now we're starting to think about more sensitive measures of disease activity, such as MRI, which in the past has not been used as a measure that allowed you to say the drug worked well enough to get it approved. It was a secondary measure, but you had to show that you had a clinical effect. We're getting the clinical effect down so low that the next thing is to get rid of all disease activity, and that will mean using the MRI. And so that's something we're thinking about. I mentioned to you that we need to come up with measures for neuroprotection. We need to develop individual metrics, the personalized medicine to determine who is it that needs to have their myelin repaired, who has to have their axon repaired, who has to have the whole neuron repaired. And that's going to be very important moving forward. We talked a bit about biomarkers, and they're coming. We want better symptomatic approaches. You heard a little bit about CCSVI. Most of the story over the last year has been decidedly negative and inability to reproduce the initial information. We need to think about the timing of our approaches, because sometimes what you do to reduce inflammation can also inhibit repair. And we need to start thinking about measures of improvement. And we've seen this with some of our trials where individuals have actually gotten better. And we have the techniques at hand to do that. And then to start thinking about measures of cure. And like you would with measures of treatment with tumors, say, well, disease-free for 1 year, 2 years, 5 years, 10 years. And these are each going to be goals for us moving forward and the next horizon for us. And so just to remind you, Dr. Kutzke again asked who was involved in a clinical trial because of the importance. We can't do this without, and so this does not represent the usual wards at Mount Sinai Hospital. They keep the mice in very nice quarters, but not next to you. But it's what we're trying to do. And to keep in mind, the only way to answer these questions, and they're difficult and time-consuming and costly, is by properly controlled clinical trials. And so if you're interested in what clinical trials are underway and in participating, there are some pamphlets and information outside with the ladies in the yellow shirts, and they'd be happy to fill you in, and we'd be happy to discuss them with you, because this is how we will move forward. And so MS, I'm going to do this quickly. MS remains an area of intense interest. There's lots going on, both in basic science and in clinical research. There's a large number of pharmaceutical biotech companies who are working in the area along with us, hand in hand, to develop new therapies. In less than 2 decades, we now have our third wave of disease-modifying agents coming on board. Risks will become an issue as we get stronger and stronger medicines, and that's why we need to individualize our care and our therapies. And what we're seeing now is different mechanisms of actions, new potential avenues of approach to treating multiple sclerosis, and developing acceptable risk-benefit ratios. And the level of interest has never been higher, and this is all very exciting. Here's a slightly distorted picture of our group. We thank you all for coming out today and for your interest, and I thank you now for your attention.